Well, thanks for the invitation, Aprecia. I'm going to try to talk about perineal trauma and the delivery position, which is a very important thing for me right now in my life because I'm living in a change of my obstetrics way to do the things. Well, this is the place where I work in Santiago de Chile, the Clínica Alemana, and the Hospital Clínico from Universidad de Chile. Well, we all know that perineal trauma is involved with pelvic floor dysfunction, but is it delivery position involved with perineal trauma? The horizontal position in delivery is defined as when the head of the mother forms an angle less than 45 degrees with the horizontal line, with some advantages suspected, like surgeon comfort and easy access to fetal monitoring, and some disadvantages, like the aortic cava compression, which leads to abnormal fetal heart rate patterns, and weaker contractions. On the other side, the vertical or upright position is defined as the head, when the head of the mother forms an angle greater than 45 degrees with the horizontal line. And these are the typical examples of the vertical positions: the standing, kneeling, sitting, and squatting position, plus the birth chair. Here it is. And the advantages are that the gravity helps the baby going to the channel. There is less aortocaval compression. There's stronger contractions, like Aldera Barcia said in the 60s. There's better fetal alignment, and it's supposed to enhance the anterior posterior diameter in the kneeling and then squatting positions. Well, most cultures have used or use the birthing positions like kneeling, squatting, and standing for labor and delivery. In 1961, Norrell and al. Published a survey of 76 traditional cultures, and 82% of them took the upright position spontaneously. This is how Cleopatra gave birth, supposedly, and we can see that she is sitting with a lot of help. In the Peruvian cultures, on the Incas, we can find this mochis. That's the name of this traditional thing, and we can see that the woman is being held by his man probably, and helped by another woman to deliver in the sitting position. The Aztec cultures and many Andean cultures show a lot of these images showing vertical positions for delivery. Birthing chairs are described since the Babylonian times, 2,000 years ago, and through the 14th and very close from now. So the horizontal position for birthing has widely been used in the Western cultures only for the last 200 years. Prior to this time, like I showed, the recorded history indicates that upright birth poses were used extensively. What happened on the way? We did. Doctors happened on the way. In ancient cultures, delivery was done by midwives, matronas, parteras, whatever the name. Those were persons very close to the patient. But in the 16th century, Chamberlain invented the forceps and started to put the patients in an horizontal position because it was comfortable to them, to him. It has been said that King Louis XIV, in a perverted caprice, liked it to watch deliveries, and he made the women delivered for him in a horizontal position, but because it was easier to see than the birthing chairs. Supposedly some queens couldn't stand any upright position because they were weak, so they took the horizontal position. And the whole thing is since the mid-20th century, the arrival of asepsia, the hemorrhage control, and the better management of maternal and fetal pathology led to a very good thing. There was the maternal and fetal mortality dropped dramatically. But the bad thing was that doctors took definitely care of delivery. Delivery was transformed in a disease. Doctors had to be in control of everything: the fetal heart rate monitoring, anesthesia, assisted delivery if abnormal fetal heart rate patterns arrived, amniorexis. And of course, the horizontal delivery was the better way to do that. What happened in Chile? And in the 60s, around 60% of all deliveries were attended in hospital facilities, and the maternal deaths rate was around 30 every 1,100 live newborns. In 2000, this maternal deaths dropped a lot to 2 every 100,000 live newborns. Actually, we can see that in Latin America, most of the countries show around 100% or over 90% of hospital or medical institution deliveries, with exceptions of Bolivia and Peru. Okay, what is the evidence that we can find right now? In 1991, Ulla Waldenström from Sweden showed a randomized control trial with 294 patients and showed no differences regarding perineal trauma when compared bathing stool or conventional semi-recumbent position. Okay, there was a little more hemorrhage in the bathing stool, but less pain, and there was no information about anesthesia use. In 1998, a randomized control trial from Brazil, in 248 patients, compared the sitting or the horizontal position during the second stage of labor and showed no differences regarding perineal trauma. A randomized control trial from 1999 with 240 patients showed no statistical differences, again, for perineal trauma. And again, peridural anesthesia was used but not analyzed. This is a systematic review from 2000 from Eason. It included 7 randomized control trials with almost 3,000 patients that, regarding perineal trauma, some of them favored and some they supported the operative position, and the other ones favored the recumbent position. There was no final conclusion. In 2007, this is Pakistani randomized control trial, showed that comparing the delivery in the squatting versus the supine position, there were no differences regarding extension of episiotomy. There were differences regarding extension of episiotomy and second and third degree perineal tears, favoring the squatting position. But there were no differences regarding episiotomy and parorental tears. This randomized control trial from 2000 took 102 patients and randomized them to birth set or any other position, not necessarily horizontal, and found no differences regarding episiotomies and perineal lacerations from first to third degree. What does Cochrane said about that? Cochrane analyzed the perineal trauma in women without epidural anesthesia, included 22 randomized control trials with 7,000 to 800 patients, comparing vertical or lateral versus horizontal, and found that there was a significant reduction in assisted deliveries, a significant reduction in episiotomies, but an increase in second-degree perineal tears. The World Health Organization, in her recommendations for delivery, favors the spontaneous pushing in the no supine position. So what can we get from all this scarce information? There's no convincing evidence for the vertical position right now, but probably it comes from the heterogeneity of studies. Most of them use epidural anesthesia, but they don't say when or if it's related with the perineal trauma. And the positions to deliver are not standardized. When epidural anesthesia is not used, there's some evidence that the upright position could reduce perineal trauma. Clearly, more studies are needed to get that question, the answer. Thank you.